Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Paresh Shah maintains a private practice in Winnipeg, Canada, with a focus on implant, cosmetic, and interdisciplinary care. In this presentation, he shares how he evolved from a tooth-by-tooth dentist into a clinician who provides his patients with comprehensive care.
Well, welcome back this afternoon, folks. So this morning what we spoke about was just everyday dentistry, just all the different types of clinical procedures that we as restorative dentists have learned over our careers and all through dental school. What I want to now move to is something in a more comprehensive or global manner, where we're actually tying all of that together and being able to treat patients as a whole. So what I'm going to do is share with you the evolution of how I have evolved in terms of dentistry, where I started to practice just tooth-by-tooth dentistry, and how I've taken my practice and my clinical skills to a different level. We know that our patients, and the demographic that's around, there's an increase in wear, missing teeth, periodontal disease, TMG and function problems. We have all of that in our practice. And they all have some things in common. They would just want to look younger, feel younger, be able to smile, not have their teeth chatter. So those are all common things that we have, but we're facing that on a day-to-day or a week-to-week basis. I'm sure we've seen all of these kind of cases in our practice, and if you haven't practiced long enough, I assure you that you will end up seeing a number of these patients in your practice. Can you put a tooth in here, she asks. What can you do? Well, sure, I can put a tooth in there, but is it going to last? Can you fix the wear here? My kids don't like the way I smile. Can we fix that? Well, of course we can, but how do we do that? How do we pick the material selection? If we just know our individual clinical skills, sure, we can spin down the teeth and put crowns on, but are they going to last? Are they going to function properly? Space. Besides orthodontics, let's say they don't want that. What can we do? Sure, I can cut the teeth down, but I'm sacrificing a lot. So how do we treat that? Now, one thing that's common, it's difficult to treat many of these conditions with a tooth-by-tooth manner. And what happens is if we do that, we're forced to ignore a lot of the underlying problems that created that condition. This book has been an impactful book in my practice. My orthodontist colleague and co-director, Tim, got me this book by Dr. Rick Robley, who's an orthodontist in Arkansas. And he's been a champion for interdisciplinary care for years. So I'm going to tell you my story based on his principles. And what Rick has broken down into dental care into unidisciplinary, multidisciplinary, and interdisciplinary care. He's actually got 4 categories. I'm going to simplify it a little. With unidisciplinary dentistry, basically refers to it as a non-integrated diagnosis and treatment planning. There's an ignorance of the other disciplines, and there's minimal to no collaboration. So let's look at a couple of examples and see if they resonate with you. This is Heidi. Heidi comes into the practice. This was years ago when the term, you don't know what you don't know, and it does happen that way. So she comes in, and this was also a time where I was taking a lot of courses by some gurus on bonding and adhesion. So I'm invincible because now I got another tool in my box and I know how to do really nice composite bonding. There's lots of other problems there, and we won't get into all the treatment planning issues, but she wanted a quick fix. So what do? I'm sorry, I went back a little too fast, but there you go. We've got this big, wide, incisal table. Is that normal? Is that going to last? We accomplished what she wanted to do, but there are a lot of sacrifices. Should we have thought about, I don't even know if I talked about orthodontics back then. I'm just being honest. I can't remember. It was so long ago. But that was, when you get out of school, you learn how to do some bonding and you just fix a problem rather than asking, why did that evolve? What will happen? What are the implications down the road? Lou, I play hockey with him. I used to play hockey. I stopped about 4 years ago. But he doesn't like his smile. He says, I got Bugs Bunny teeth. And he's getting married in a couple of months. I mean, that does influence things. But he said, what can you do? And I'm thinking, okay, we can do some veneers. We can do I can fix the teeth up, and we can do 8 or 10 of them. All I'm thinking about is, hey, I know how to do veneers, and I can fix them for you, and my lab can get that done fairly quickly. What do? We do 4 veneers, fix some of the issues, but there's all sorts of things. We really should have been looking at everything. And even if, nowadays, even if you've got orthodontics, maybe we could have started with some Invisalign and transitioned him and still done a great job, and he could have had his wedding. But these are things, I didn't even include the other disciplines. I'm not passing it on anyone else. And us restorative dentists here, that's our obligation. We need to be focused on that. And that's what we're trying to learn here in these kind of study clubs. So did we get success? Sure. We've accomplished goals within his comfort level. This is Darlene, one last one. And she said, I never smile. I just want to have my smile. And all I'm focusing on is that, hey, I can do 6 crowns. I'm excited. This is just a short time after being in practice. So I did 6 crowns. She's still happy to this day. I mean, this is like 20 years ago. But look at all the other things that we could have done. And it still was stable. But I'm lucky in some ways. Multidisciplinary dentistry. Robley refers to that as the awareness of the benefits of other disciplines. It's an unstructured collaboration, and the goals are separate. So let's look at multidisciplinary. This is one of my first implant cases in my practice. I'm about 1.5 years into my own practice, about maybe 4 years out of school. She comes in and says, I want dental implants. I'm excited. I get to do multiple dental implants. I call my oral surgeon, who I actually trained with and did an internship at the hospital with, so he's a slick surgeon. We did not talk to one another at all. I said, hey, put in these dental implants. I promise the patient I'm going to give her teeth that she can floss in between, that there won't be any metal showing, all of those things. She comes back to me after she gets the implants done. I send it off to the lab, and the lab goes, you told her what? How can I make these individual? How can I hide the metal? No communication at all between either of us. No records at all. Proper treatment planning, mounted cast. That's multidisciplinary. An ignorance of, not just an absence of that communication. I knew what he can do, he knew what I wanted, but we didn't talk about the end result. And so he did his thing. And he did what I asked him. He didn't ask what the patient wanted and what I had asked the patient. So we didn't communicate that at all. We both have to own that. It worked out, but it could have been a lot better. Now we have to start creating excuses rather than informed consent. That doesn't work very well, especially in 2015. This is Cliff. Needed an implant on a failing tooth, had his perio looked after first by the surgeon, and then needed this tooth taken out and an implant placed. Provide a surgical guide. Want the implant put in. Get a call from the lab on a Saturday, because that's when the periodontist actually did the surgery, and said, you got to come and see this. I go, what? Come to the lab right away. I go to the lab. This is what I've got. Looks like a rhinoceros. It's sticking straight out. I did not get my surgical guide back. He got swayed. He just kind of was doing it, didn't have bone, put it wherever he wanted it. And that's multidisciplinary. We're not communicating. He's got one goal, I got one goal. We wanted that patient goal. And so this implant is running sideways over here. Not good. What did we do? He didn't want it trephined out. We actually did a bridge. This was the case that made me want to learn more about implants and start placing some of my own. Now I have a periodontist and an oral surgeon, and the perio works in my office. But before that, I still place some of my own. Let's look at Jessica. Jessica is about 21, 22 years old, comes into my practice. She was actually driving by because she lives about an hour out of town, and she drove by with her parents. And sweet young girl was going into education, or she was in education at the university. And she said, I really don't like, I'm missing a lot of teeth. And I don't like what I see here. And I've got this appliance that I have to keep taking in and out. And I don't see myself long-term having this appliance and putting it in a glass. So I really want to have dental implants. I don't want to do anything invasive on my teeth. And I said, okay, and I'm looking at it, and I'm trying to ask her some questions with her parents on what she's looking for. And I said, look, as I'm talking to her, now I've got more tools and a little more skill that I've grown with over the years. And so already I'm several steps ahead of her, and I'm asking the questions that I know she's going to ask. And I said, okay, well, one thing you're going to need is, I do place dental implants, but this is more complicated. So you need someone who has the skill to places thousands of implants and knows what to do. So you are going to have to see a surgeon of mine. You might have to have some bone added. I can't tell you yet. We didn't have CT scans back then in our city. So, it was going to be the surgeon's assessment. And as I'm looking at the roots of the teeth and the positions, I'm saying, they don't look like they're inclined properly. So I said, I might have to have you talk to my orthodontist. And she said, you know what? I just finished 4.5 years of braces. And I just kind of stepped back and I said, excuse me? She goes, well, I live in the country. My general dentist sent me to an orthodontist who sent me to a prosthodontist. And it's just been sitting on their desk for 9 months and I'm getting tired. I just want to get my work done. And I said, do you mind if I call the orthodontist? She said, no, not at all. He's a really nice guy. They never spoke. He said, I'm sorry, I know this happened. I'm glad you called because I want to help her. Because nobody gave me direction, the general dentist or the prosthodontist. And I said, are you willing to start over again? He goes, whatever it takes. I really like this young girl. And he says, I know that we should know that we got to head to ideal treatment, but we just never did it and we weren't taught that way. So this is divergent roots. We've got primary teeth that are still in place. We've got space appropriation issues. There's all sorts of problems. That's multidisciplinary. No one communicated. It's like, you know what, go off to the orthodontist. They're the specialists. They'll be able to figure it out. But it would have been nice to say, you know what, if we need to put dental implants in, I just need space for them between the roots. Can you please do that? And that's all it takes in writing or by a phone call. But none of that was done. Multidisciplinary. We use that term too liberally in medicine and dentistry. We go, yeah, we've got a multidisciplinary practice. Sure we do. You got all the disciplines there. But are you communicating with one another? A lot of times, even in medicine, we don't do that. And we need to do that. And that's why we're redefining some of this. I'm going to finish that after. So what are some of the things that you need to do to get yourself on track? One thing is treatment planning with the end in mind. We really need to do that. Peter Dawson said, to have an accurate starting point, every problem to long-term health must be identified and plan it to a complete visualized endpoint. Okay? So that's one of the things. We need to have the provider who's responsible for the final prosthetic phase to be managing all the treatment and coordinating all that. It's very, very important. It doesn't mean you have to be a stickler and to boss everyone around, but someone has to own it and manage it. You serve like a general contractor. You be involved in the planning, vision, and strategy and organize an interdisciplinary team. We have to look at things from a restorative perspective, as restorative dentists. And the specialists look at it quite often from a specialist perspective. What we need to do is use interdisciplinary eyes. And both parties have to start looking that way. We have to recognize the roles and strengths of the other disciplines that are available to us. And we have to work together and be involved in all of that sequence. The collective wisdom is greater than the additive wisdom of the individual parts. Through discussion, we can potentiate the knowledge. This was a quote from a general dentist in an interdisciplinary conference that I attended probably about 8 or 9 years ago. It stuck with me. And he was standing there with his surgeon and his orthodontist, and I said, you know what, that's great. And I looked at both of my friends on each side. I said, we're going back home, and this is what we're doing. And we did. We really have. It's been a lot of fun. We need to put together, we have to decide for those super dentists out there, which I tried to be for the longest time, like, can you really accomplish that work? Or can the patient benefit from having someone else's specialty in there? You've got to really look at that, because you know what, if you make a happy patient and you do comprehensive care, there's still going to be a patient of record in your practice because they're going to appreciate it. Trust me, because I've been through that, and a lot of people have been through that. But you need to also interview these specialists and make sure that they want to work with the style of practice and the philosophy that you have. If they don't, move on. Patients will go to who you ask for if they trust you, even if it means driving, half an hour or an hour away. But speaking of collaboration, how do we accomplish all of this? Well, interdisciplinary care. This is how Robley defines that. And I fully agree with that. It's a working common knowledge. We think alike. And collaboration. It's a structured collaboration. We have common goals. Okay? So let's talk about Jessica again, just as a reminder. I mean, she had all these missing teeth, congenitally missing teeth. We want to try and help her. I spent a lot of time talking to her about, does she want the tissue heights and the gums all even? Because she's already gone through 4.5 years of braces. She goes, Dr. Shah, no, this is not something that I need, but I just don't want to take the teeth out and I want it to look nice. And so we can accomplish that. What do? Visualize the end point. I ask her the questions. I ask her what she wants to accomplish. Now I sit down with my lab. Can we get her there? Let's do that. Then I call the oral surgeon. Now it's interdisciplinary. I call the oral surgeon, I got the orthodontist. We meet at the surgeon's office. Can you do it? He says, yes, I can. I need you, the orthodontist, to get the teeth in this position. I'm going to monitor how you're doing that. So we start communicating now and treatment planning from that starting point. We take radiographs because we didn't have certain things that were available at that time, like cone beams. So we take the radiographs and I send it to the surgeon, who sends it to the orthodontist. Said, I need you to move this tooth here. I need you to move this tooth 18 months later, okay? But we get it. We get the teeth and we get the space that we need. She's a patient young girl. Now she's, in her, getting close to her mid-20s. We need to start placing implants. So what do? He needs to know where I want the implants so I can get the prosthetic results as best as I possibly can. So he needs to do grafting, a surgical guide. We didn't have, cone beam surgical guides at that time, so we fabricated lab ones. He placed the implants, now we get our impressions. Once we finish our impressions, we try the abutments in. And now the patient, I can communicate again because I've been talking to her about aesthetics and I've been explaining to her that I have to do work on the other teeth. But she wasn't really visualizing it until we see that and go, look, you don't want 4 front teeth on the top. You can have it on the bottom. And now she realizes and says, I see what you mean. What are you going to do with the rest of them? Like, well, if you don't want to do, her parents were paying for all of this treatment. They're already spending a lot of money. So she said, can we do something temporary on those teeth? And then as I can afford money when I become a teacher, I can start doing ceramic. I go, absolutely. So I sit with the lab and we do a diagnostic wax up, visualizing the end point. Keep going back to that. And we do some transitional bonding along with ceramic. You can easily mix and match all that. If you've got stable occlusion, you can turn this case into a tooth by tooth, quadrant by quadrant case. And that's what we've done. And we've mixed and matched that. And she lives in England. She teaches there now. She comes back to visit her family every year or two, and she'll come to the office and we'll do a couple of more teeth for her. But that is interdisciplinary care, okay? Working common knowledge. We're thinking alike. We have structured collaboration and we have common goals. So what do we learn from this? Teamwork. It's very, very important. Can someone do it better? You have to ask yourself that. If they can, let's get them involved. The diagnosis, treatment, planning, and execution. We need all the disciplines to be at least considered and involved wherever they need to be. Communication throughout. It has to be structured. Very, very important. And our goals. We have to be common goals for the patient, visualizing the endpoint. Very, very important. Okay? I thank you for your time. It was